Hello, everyone, and welcome to our March 2021 Ask the Doctor webinar. My name is Shelley Kurian with SkyPass Foundation, and we are here to discuss sleep disorders in Parkinson's disease. As you all know, sleep disorders is one of the most common non-motor symptoms in PD, and here to answer all your questions about this topic is our guest speaker for tonight, Dr. Amy Amara. Dr. Amara is a physician scientist at the University of Alabama at Birmingham. She has fellowship training in both movement disorders and sleep medicine with a particular interest in sleep dysfunction and other non-motor symptoms in patients with PD. Dr. Amara, it's an honor to have you here with us tonight, and I know our attendees are excited to hear from you and have already sent in a ton of questions, which we'll get to later on in the webinar. Also joining us tonight is Dr. Shilpa Chitnis, SkyPass Foundation board member and professor of neurology and movement disorder specialist at UT Southwestern. Dr. Chitnis will be moderating tonight's discussion. If you're joining us live on Zoom, please use the QA or the chat box at the bottom of your screen to keep your questions coming throughout, and we'll try to address as many of those as we possibly can. And with that, Shilpa, it's all you.
I want to start out by saying thank you to everybody that's here. I hope these sessions are very beneficial. Please feel free to ask any questions in the chat box or at the end of the session. So, Amy, let's start out first by saying, sleep disorders in Parkinson's. When do you see them? Do you see them early in the course of the disease? Do you see them later in the course of the disease? Are they pretty much a part and parcel of the lifespan of a patient with Parkinson's?
Well, they can really come almost at any time. There are a lot of patients who experience sleep problems even before they're diagnosed with Parkinson's. So like things such as REM sleep behavior disorder, where patients act out their dreams and fighten their sleep and sometimes can even get injured with that. That can happen many years even before Parkinson's symptoms appear. And then there's a lot of other sleep disorders. Once Parkinson's is diagnosed, there can be insomnia. And then as the disease gets more advanced, there might be trouble rolling over in bed that can lead to discomfort during sleep and sleep fragmentation. So really quite a broad range of sleep disorders in Parkinson's, and they can affect different people at many different times. And, as you know, with many symptoms in Parkinson's disease, every person is a different person with Parkinson's. So the variety of when the symptoms affect people can be quite broad, and different people have different experiences.
Yeah, thank you. And then would you say that, in addition to the fact that we work so hard on controlling the motor symptoms of Parkinson's disease, but something like a non-motor symptom, which is sleep dysfunction of various kinds that we're going to talk about, really, would you say, impact quality of life of patients?
Oh, absolutely. I think it's one of the things that my patients talk to me about the most. And I don't think that's only because I ask questions about sleep and that's one of my areas of interest, but my colleagues say the same thing, that sleep complaints are really, really common, and it can range anywhere from sleep disorders that affect the general population, like sleep apnea, or to things that are more specific to Parkinson's, like the REM sleep behavior disorder. So it's really quite a broad range.
Yeah, absolutely. So before we dive deep into talking about each individual sleep-related problem in patients with Parkinson's disease, maybe you can just walk us through for our audience, for the various stages of sleep, just, briefly.
Sure. So, of course, they're the behavioral states, as we call them, that are divided into sleep and wake. And then sleep itself has two main different categories. There's the non-REM sleep, or the non-dream sleep, and then REM sleep. And REM, of course, stands for rapid eye movement. So interestingly, REM sleep is when our brain is most active. And that is most commonly when dreams occur. But during that time, the normal state is for our body to be paralyzed, so that we can't act out dreams. And of course, that's disrupted in REM sleep behavior disorder. And then the non-dream sleep, or non-REM sleep, there are actually three different categories of that. So there's the light sleep or drowsiness, that's non-REM stage 1. And then there's non-REM stage 2, which takes up really most of the night. It's usually like 50 to 60% of the night. And then non-REM stage 3 is an area that I'm really interested in because it's slow wave sleep is another name for that, or delta sleep. And that area or that type of sleep has been associated with being important for learning and memory. And so having reduction in that area of sleep can be disruptive for thinking and cognition. And of course, that's very important in Parkinson's too.
Yeah, I mean, I think it happens to, normal. I mean, I'm saying normal as in non-Parkinson's people. When I don't sleep well at night and I'm getting older, I think I require more caffeine and I, make some mistakes with typing, right? So, I mean, these are simple things. And so you can just imagine that somebody with a neurodegenerative disorder, then that would certainly be very problematic. So, why don't we talk about like each individual, so let's just start like with, you know, um, difficulty with initiating sleep or difficulty with being able to maintain sleep, which would be, I guess, part of insomnia.
Yeah, so that's sleep onset insomnia and sleep maintenance insomnia. So, sleep onset insomnia is very common in the general population, but also can really impact people with Parkinson's disease. And sleep maintenance insomnia, or trouble staying asleep, is really pretty common in Parkinson's, and it's probably 3 times more common in Parkinson's than similarly aged older adults. So sleep onset insomnia, sometimes that can be related to anxiety or depression because, if you have racing thoughts or trouble just shutting your mind off at night, that can really lead to trouble falling asleep initially. And then there are lots of sleep disorders that can contribute to trouble staying asleep. So if you have sleep apnea, meaning that you can't breathe very well during sleep, those breathing pauses can lead to you waking up at night. Or if you have leg kicks, which is really common also in Parkinson's, frequently kicking your legs through the night, that might lead to waking you up. Acting out dreams can wake you up and disrupt your sleep. And then, as I talked about before, if your medicines wear off during the night and you become more stiff and slow from your Parkinson's motor symptoms, then you might have trouble rolling over in bed. And this can, when you don't have Parkinson's, if you're uncomfortable during the night, you probably just roll over and never wake up. But if you are stiff and slow and maybe need assistance rolling over or have to work really hard to get your body to move, then by the time you finally change position, you're wide awake from all that effort. And so that can lead to a lot of trouble getting back to sleep after you've, increased your heart rate and really worked a little bit to get things moving. And then, there is also early morning awakenings, which is a type of the sleep maintenance insomnia where people wake up earlier than they would like to. And this can happen as we get older. Also, our circadian rhythm changes a little bit and people tend to want to fall asleep earlier in the night and might wake up earlier. And that can also be affected by depression. Depression can also lead to early morning awakenings. And then if you're not sleeping well, like you said, you don't feel well, and that can affect your mood too. So, so there's a real bidirectional relationship. Mood influences sleep and sleep influences mood. So it can be hard to handle both if you can't fix one first.
Yeah. So, and like you said, that, if let's say that if I slept at 9, I usually sleep 6 hours and I got up at 3, then technically, like I've actually, slept, but, at 3 o'clock, I mean, I don't go to work at 3 and then, trying to go to sleep. So I think that, I guess each individual, patient needs to be able to also figure out their own sleep rhythm, so to say, isn't it?
Yeah, that's absolutely true. Everybody has a slightly different time when they prefer to be asleep and awake. And sometimes when you have to go to work, if your preferred sleep time goes past the time that you have to wake up for work, it can lead to sleep deprivation and daytime sleepiness and problems like that. But I do want to say, you should increase your sleep time, Shilpa. You need more than 6 hours.
Oh my goodness, I think
We
I will.
really encourage people to get 7 or 8 hours of sleep.
And is
Need
that
7 or
true?
8 hours of sleep at least. So,
Is
and
that true for
you
everyone?
yawned right on cue.
Oh my goodness, I don't think I've ever slept more than 6 hours.
That's true for most people.
Yeah. Uh, and I
I mean, there are rare people who don't need it.
Yeah, but I mean, this is obviously off topic, but for most of us, including our patients, I mean, people, young onset people, people who work. I mean, Brenda's on here, and she and I always have this talk about the amount of work that we have to do even after we come home. Like, I mean, I really want to, ask this question about the what is recommended and what is reality, and the reality of all of our lives, including us, you and I being in academic medicine, grand deadlines, papers, didn't finish my notes, if I don't get it done now, when will I get it done? I mean, how can I ever do 7 or 8? Reading the papers, right? I mean, for us to be defined as experts, we have to keep up with what we read. The people who work as IT professionals, I mean, they have deadlines. I mean, how do you juggle all of that and still try to get, restful sleep? And do you think compensating with sleeping maybe a little extra over the weekend, is that the solution? I mean, what's the solution for busy people like us and busy people like our patients with Parkinson's? How do we, I know my patients who are young onset and they work, Brenda works quite a few hours. How do you catch up?
So the best thing to realize is if you give sleep a priority, it will help you be more efficient with your work. So to make sure you get enough sleep can really help with your day-to-day function as well. But of course, we all get overwhelmed and behind, and so just focusing on your health and realizing that maintaining that level of sleep is really, really important to continue functioning well and to be healthy and safe is really important, and it does need to be a priority. And can you guys hear me okay still?
Yeah. You're good. You're back.
Okay,
Um,
great.
yeah. Okay. So that's really good. So let's talk about excessive daytime sleepiness. I mean, uh, you kind of kind of alluded to the fact that what are the problems that if you don't. So what can you tell us about excessive daytime sleepiness in patients with Parkinson's?
So there are a lot of different ways to get sleepy when you have Parkinson's. So first of all, some of the medicines that we use can cause sleepiness, like pramipexole and ropinirole, and some of the dopamine agonists are really notorious for making people sleepy. So sometimes changing the timing of those medicines can help with sleepiness, or taking scheduled naps or scheduled exercise can help with sleepiness related to medications. Or maybe getting on long-acting medicines that are less likely to cause sleepiness. And then another thing is that, if you're not sleeping well at night, of course, you can get sleepy during the daytime. So, I send a lot of patients with Parkinson's to get checked for sleep apnea in case that might be causing them to be more sleepy than they should, or looking for those leg kicks during the night or other things that might be causing fragmentation of sleep that can be treatable so that we can make them sleep better during the night. And then, one thing that's hard to make better is that when you have Parkinson's, you have some neurodegeneration of the brain, and part of that area that can degenerate is the brainstem. And that is a very important part of the brain for keeping us awake. So you can get actually changes where people sleep really great at night, but they're also very sleepy during the daytime. And so that one's hard, especially for spouses to deal with, because they see a change in their partner who used to sleep normal amount of time, and now they're sleeping hours and hours of the day. So again, exercise and scheduled napping can help make the day flow a little bit better. So if you typically get sleepy after lunch, just go ahead and schedule a short nap, like 20 minutes for that time, so that you're not consumed by sleepiness all day long, but keep a scheduled time where you can take that nap when it's most helpful, and then maybe get some more productive things done for the rest of the day.
Or get some caffeine like me.
Right. And it's interesting when you said caffeine earlier, that was right after I was talking about that non-REM stage 3. And one thing that our body does as we are longer awake, our body has a sleep drive that builds up, and that's actually driven in large part by adenosine. And caffeine inhibits adenosine, so that's why it helps us. So adenosine is the culprit for our sleepiness sometimes.
Yeah, and could be neuroprotective in people to not develop Parkinson's, maybe.
Right. Caffeine can be associated with lower risk for Parkinson's.
Yeah. Um, let's talk a little bit about sleep attacks, especially with dopamine agonists. We are seriously not using a lot of dopamine agonists, but there's still population that is on dopamine agonists. So what can you tell us about that?
Yeah, so that's really interesting because when dopamine agonists started being used, that's really when the association between Parkinson's and sleep problems kind of came to light, because we were getting better at treating the motor symptoms of Parkinson's, but we started noticing that people were, suddenly falling asleep, and it led to drowsy driving, and sometimes there was no warning about feeling sleepy, and it was finally discovered that that was related to the dopamine agonists in some people. It doesn't affect everybody that way. But yeah, so it actually was, a scary thing, but also led physicians to start exploring the non-motor symptoms and recognize that sleep is a problem in Parkinson's. And so that really helped us understand that. So again, if you have that condition where you've become really just uncontrollably sleepy after taking your medicine, really important to tailor your day, arrange your day so that you don't have scheduled driving after you've just taken your medicine, or take your medicine and plan that, okay, I know in 30 minutes I'm going to feel extremely sleepy and I just need to schedule a nap during that time so I can plan for that and then move on with my day. Otherwise, you might end up having an accident while driving, or making a mistake at work, or falling asleep during an important event or something like that.
So is it that these sleep attacks happen, when you have initially introduced these medicines, or is it that after you've been on a, like a steady state dose of the medicine, that the risk of the sleep attacks perhaps gets better?
Sometimes it does get better. We often see it, if it's going to happen, usually see it when the medicine started. But some people just can't tolerate those medicines and the sleep attacks never go away. So if you're having them and they're severe and they don't seem to work with your schedule, it may just require changing medications.
Yeah.
Yeah.
But I mean, there was some data with when rotigotine patch came out that maybe it was good. And I know that the company had some data that they had not even published, that sleep fragmentation was perhaps reduced with using rotigotine. Like, is there a role still? Is a dopamine agonist totally dead, or is there a role for maybe rotigotine patch in people who are having sleep problems that that aren't older and not hallucinating? What
Right.
do you think
Yeah.
about?
I mean, we certainly still use dopamine agonists sometimes in our practice. And yeah, I think they can have a benefit. Like, if you combine low dose dopamine agonists with low dose of levodopa, a lot of times you can reduce the side effects of having both together. So there definitely can be improvements in sleep related to any of the dopaminergic medicines, because not only do they kind of make you sleepy, which might help you sleep better, but also they can help with those movement problems and might help you, roll over easier in bed, or just have less tremor during the night. And so if they're not causing trouble with daytime sleepiness, or like you said, some people do get hallucinations, but that can happen even with levodopa. So I think there's a role for those medicines still, in the right person.
Yeah, no, absolutely. Um, let's talk a little bit about sleep apnea, and maybe you can tell us a little bit. Is sleep apnea like really common in patients with Parkinson's disease, or is it got to do something to do with certain body habitus, or any other risk factors?
Yeah, so sleep apnea is just common in everybody. So, I mean, of course, not everyone has it, but in the general population, about 4% of men have sleep apnea, and 4% of women, and about 7 or 8% of men. So it's really just very common, and it does get more common as we get older. So, Parkinson's disease is a disorder of aging as well. So as you get older, you have higher risk for Parkinson's and you have higher risk for sleep apnea. There's some pretty good studies showing that Parkinson's patients don't have any higher risk of sleep apnea than the general population. But of course, untreated sleep apnea can lead to a lot of significant health problems, like increased risk for stroke, increased risk for heart attack, increased risk for cognitive problems, which, if you have Parkinson's, you're already at some degree of increased risk for that. So you certainly don't want to add sleep apnea to that picture. So it is very common, but not necessarily more so in Parkinson's. And basically what sleep apnea is that for obstructive sleep apnea, as you're breathing and you fall asleep and your muscles relax, your airway can collapse because your muscles aren't as firm to keep your airway open. And so when that happens, you're trying to breathe against a closed airway and your oxygen level can drop, and it puts stress on your heart and makes you pee more at night and makes you have night sweats and dry mouth in the morning and morning headaches and a lot of different health problems and consequences. So if you have any of those symptoms, snoring, pauses in your breathing, it's really important to get that checked out because, like I said, it does increase risk for other health problems like stroke and heart attack.
And does weight loss, is that a good, would you say that there's a good correlation between weight and OSA?
Yeah, certainly. So if you have a higher body mass index, that does increase risk for sleep apnea. If you have a family history of sleep apnea, that also increases risk. Other things like certain facial features, like if you have your lower jaw is recessed relative to your upper jaw, that makes your airway more narrow and can increase risk for sleep apnea. So, I think in general for Parkinson's and for sleep, exercise is super, super important. And you can actually, if you exercise, you can reduce your sleep apnea if you have it, even if you don't lose weight. So there is definitely a relationship between obesity and sleep apnea, but you don't have to be obese to have sleep apnea. You can be super skinny and still have it. So getting it checked out if you're not sleeping well is a good idea.
Thank you. But the biggest problem is that not everybody is very comfortable with with the BiPAP or the CPAP. It's not, is there a newer, modified, technologically better versions of these things coming up?
There are always people looking for better forms of this. And sometimes people just have sleep apnea only when they're sleeping on their back. And so if they roll to their side, they might not have sleep apnea anymore. So there's positional therapy, we call it. And then there are different ways to get better used to CPAP and BiPAP. There are lots of different types of masks, and there are newer masks every year. So sometimes people who hated CPAP 10 years ago can really love it now. There's also a hypoglossal nerve stimulator, which is actually kind of like DBS, kind of like a pacemaker. You have a little battery under your clavicle, and it actually, you turn it on when you go to sleep, and when you take a deep breath in or any breath in, it pulls your tongue forward to open up your mouth a little bit better, open up your airway. And then there's some newer therapies. There's actually something I saw recently where there's a thing that you just put inside your mouth, so it doesn't cover your nose or mouth, but it helps to treat sleep apnea as well, depending on how severe your sleep apnea is. So there are new things being developed all the time. And there's also, you can use oral appliances that help move your lower jaw forward to help with sleep apnea.
Yeah, absolutely.
Great question.
Good to know. Lots of good options. What about bruxism or teeth grinding? Is that something that you see often in people with Parkinson's, or what causes that?
We see bruxism mostly in people who have college education and have some anxiety. That's the most common people we see it in. And it is really hard to treat. Like there's not really a medication that will take it away or stop it. So the most important thing is to protect the teeth and make sure you don't grind your teeth down at night so that they don't become useful for chewing anymore. So working with your dentist to get a mouthpiece to put in to help with and protect the teeth is really important. But as far as it being more common in Parkinson's, that's not something I have read about or really seen in my patients. So are you aware of it being more common? Okay.
No,
I didn't.
not at all. But would you say that would indicate that what if you do not have any symptoms of anxiety that you would think as traditional symptoms? So if somebody didn't have that but had bruxism, would you consider that as a sign of anxiety?
If they don't feel anxious in their symptoms, I wouldn't say that just having bruxism doesn't mean they're subconsciously anxious or anything like that. But just mainly it is unfortunately really hard to get better with any therapy. Like even people who get the mouthpiece, they still are grinding. They just have the protection of their teeth and hopefully reduction of the noise, which I think can bother some bed partners if someone is making that grinding sound during the night.
Yeah, thank you. let's talk about restless leg syndrome, and let's talk about periodic leg movements. Uh, Certainly, is restless legs a risk factor for developing Parkinson's disease, or just a mere association?
It's more common in people who have Parkinson's, but so many people have restless leg syndrome, and it's not been shown to be a risk factor for later development of Parkinson's. Parkinson's also causes the akathisia, that symptom that just gives that restlessness and need to move. So the way you can tell the difference, of course, between restless leg syndrome and akathisia is the restless leg syndrome is really worse in the evening hours, or really sometimes only in the evening hours. But it can certainly lead to problems with falling asleep and staying asleep. And some of our Parkinson's medicines, of course, make the restless leg syndrome better. But it's also really important to check for other things, like low iron can really cause restless legs, and sometimes the RLS will completely disappear if you treat the low iron. Low vitamin B12, low vitamin D, thyroid problems, all that can cause restless legs. But again, going back to the ultimate treatment for everything, if you have a consistent exercise program, it can help reduce restless legs and those leg kicks at night. And then, of course, there are medications that can help with it too, in addition to the Parkinson's meds. So a lot of ways to make RLS better.
And pregnancy. So if you're
Oh,
pregnant
yeah.
and you deliver your baby, your restless legs get better.
Right, because the iron issue, right? Yeah, or if you have kidney problems and you get a transplant, your restless legs will get better. So,
Yeah, absolutely.
yeah.
Um, and then I want to talk about, last but not the least, is REM sleep behavioral disorder, which I think of all of these, maybe USA with the antecedent risk that it carries, but of all of them, I mean, I think all of these sleep disorders can certainly result in risk for accidents, right? Risk for falls. So
Right.
so important to address them. But let's talk about REM sleep behavioral disorder, where not only do you, excuse me, are at risk of injuring yourself, but you're also at risk of injuring your bed partner. So, what can you tell us about that?
Yeah, so like I mentioned before, when we're in dream sleep, the normal status is for our muscles to be paralyzed, everything except for our eye movements and our breathing. So, and that's a safety mechanism so that we don't act out our dreams. And probably because of, again, neurodegeneration in that brainstem area, that's where the signal to paralyze our muscles comes from. And so when that area has degeneration, then it can lead to movements during sleep. And the really fascinating thing about REM sleep behavior disorder is that it really can be highly associated with Parkinson's, but happen for many years before the Parkinson's motor symptoms start. And so it can almost be predictive and actually lead to
I'm gonna
uh,
call Tino.
kind of us knowing that the symptoms of Parkinson's might develop later. Which makes it an exciting area for research, because if we can identify people who have REM sleep behavior disorder, once we develop agents that are neuroprotective for Parkinson's or curative for Parkinson's, the people who have REM sleep behavior disorder will be a great group to intervene in. And they can also tell us something about what happens in the brain before Parkinson's is showing up as its motor symptoms. So really exciting area to explore, but also can be really dangerous to the people who are experiencing it and frustrating to bed partners and to patients. So one of the most important things is to make sure that your bedroom is safe if you're acting out your dreams. So you definitely don't want to have any weapons in the bedroom. If you have any guns in the house, you should lock them separately from any ammunition. And keep them, certainly don't have a loaded gun under your pillow. This may lead to you shooting your bed partner when you're acting out a dream. I tell people to, survey your bedroom. If you happen to hang a picture that day, don't leave the hammer on the bedside table. Or if you were cutting something up with scissors, don't leave your scissors on the bedside table, or you may end up really injuring your bed partner, because people do kick and punch and fight, and it's not any subconscious desire to hurt anyone. It's usually that they're having dreams that are scary, that someone's attacking them or attacking someone that they love, and that they're trying to fight back and protect themselves or their family member. So it is a scary thing, but there are definitely ways that we can try to make it better. So like I said, making sure your bed's not next to a window. If you are falling out of bed during acting out dreams, putting your mattress and box springs on the floor, moving any kind of bedside table farther away from the bed so that if you do punch out, you won't, hit the bedside table. And just, kind of looking at the bedroom and making sure that it's overall safe. And then there are medicines that can help reduce the dream enactment behavior. So sometimes when people start their Parkinson's medicines, they notice a dramatic reduction in the acting out dreams. And that's partly because medicines like levodopa can reduce the amount of REM sleep we get. So that can lead to less acting out dreams. But then there's also things like melatonin and other medications that can reduce those behaviors and help us be safer at night. That was a long answer. You're muted still, Dr. Shah.
Right. Do you use a lot of clonazepam? And my worry with clonazepam is always that would people fall risk certainly increases with clonazepam. So do you still use? I mean I use it too, but always worry about fall risk.
Yeah, certainly. And I worry about sleep apnea risk because if you already have some mild sleep apnea, taking the Klonopin or clonazepam can make you more likely to have sleep apnea at night. So yeah, I do occasionally use it. I try not to use it in anyone who's got untreated sleep apnea, but I tend to go for melatonin first. And if they're on a good dose of medication of melatonin and still acting out dreams, then I might add clonazepam, but always at a very low dose. It's unusual to need more than 1 to 2 milligrams. I usually start with 0.5 milligrams and just have them take half a tablet, and sometimes that's plenty. So but the fall risk, the risk for depression, the risk for sleep apnea being worse is a big consideration with clonazepam. So you have to be cautious, but you also don't want someone falling out of bed and hitting their bed partner during the night. So it's got to be a balance.
What's the highest dose of melatonin that you use?
I usually stop at 9 or 10 milligrams. I usually start at 3 and give that at least a month to see how it's working, and then go to 6 and then maybe 9 or 10. I have seen patients come from other places on 40 milligrams of melatonin.
That's fine.
Yeah, I haven't seen any data saying that that's any more effective. And the two, I think I've only had 2 patients like that were on that high dose, and a lot of times they weren't noticing any improvement either, and we actually tapered it off and it didn't get worse. So I'm not, or tapered it down maybe, but
You're saying sorry, go ahead.
Oh, I don't know that there's any evidence that those super high doses of melatonin are any more effective.
So if you are not better by about 10 milligrams, now, is there a thing that you have to take it about 1 to 2 hours before bedtime rather than at bedtime? Because, if you take it at bedtime, maybe it doesn't work, but take it 1 to 2 hours prior to bedtime.
I usually say 30 minutes before, because it does usually start acting by that time, and it can help with sleep onset a little bit. We use melatonin sometimes to set the circadian clock also. And usually for that, you need to take it quite a lot earlier, like around 5 or 6 p.m., depending on your typical bedtime. So it depends on what you're using it for. But for RBD, I usually use it about 30 minutes before bed, because it doesn't last super long either. It goes out of your system in a few hours. So having it a little bit closer to bedtime can be helpful for the acting out dreams. That's a great question.
Yeah. No, thank you. And I see people who are on the combination of, like you said, clonazepam and, one of the things that a patient had basically shared with me is, just putting, sleeping on the floor, like having the mattress on the floor, and, that was helpful to them. Like they weren't like, that way the risk of falling out of bed was not much. And then, but I have to say one word, and I'm sure Amy, you agree with me, is that it's really important to treat REM sleep behavioral disorder, because one of the things I see is that a spouse will basically leave the room and then go sleep in another room. And I think to me, that's like super isolation. Like if, already if you're getting into advanced stages of Parkinson's disease and your spouse decides to go sleep in another bedroom, because of, we sometimes do it voluntarily, right? Oh, I got to work at night, I'm going to, go sleep outside. But if you're doing it on a regular basis, I think that, introduces a little bit more isolation that you probably don't want. So I think I definitely put a pitch for treating sleep apnea rather than not treating it. What do you, don't you agree?
Yeah, I mean, I always treat RBD if it's leading to injury or disrupting the patient or their bed partner's sleep significantly. Now, if people only have a little bit of talking in their sleep, maybe once a week, and it's not terribly bothersome, I don't always start medication. But if they're doing things that are injurious, I certainly treat it. And then if it's frequent enough that it's causing problems, then I also do. And one other thing I didn't mention, but rivastigmine, which is a medicine that we use for memory, can also help with RBD. And I usually don't prescribe that unless somebody has memory complaints also. But it also can help a little bit with hallucinations. So it's a good medicine to use if someone's having all three of those problems.
Yeah, very good. Well, let's talk about no. So last kind of disorders like people who do not have REM sleep behavioral disorder, but they can have basically nightmares and vivid dreams. Like, what do you tell those patients?
Um, that can sometimes get better if you get a little bit better consolidation of sleep, meaning, better overall sleep quality. So, I don't prescribe a lot of sleep aid medications, but occasionally if someone has depression, I might prescribe trazodone, which can help them sleep better. Or really, again, encouraging exercise, because I think that does help with preventing awakenings during sleep and helping people sleep better. So that can reduce the awakenings during dream sleep that might make you remember those vivid dreams. I also sometimes encounter people who love their vivid dreams and really look forward to their their fascinating dreams at night. But yeah, if they're really having trouble with vivid dreams, sometimes actually stopping melatonin can, melatonin sometimes can make your dreams a little bit more vivid. It varies from person to person.
And I've seen dopamine agonists also start with vivid dreams once, when they start
Yeah.
them at times. Okay, so very good. Thank you. I want
Yep.
to just talk a little bit, couple more things, and then we'll open it up for questions. So, um, sleep hygiene. Like, what is your sleep hygiene blur that you tell your patients? Like,
Okay. Yeah. We have these discussions very frequently. So, in this day and age, it's really easy to develop bad sleep habits because we have, you know, uh, things are activating all the time. There's light everywhere. We have, compared to caveman times where we just went to sleep when it got dark, which is kind of what we're designed for. So really, really important to keep a consistent schedule because we do have a circadian clock. Our brain knows when it's time to be asleep and when it's time to wake up. And if you vary the timing of that, then your clock gets confused. And so it's really important to have a consistent schedule. So you get up the same time every morning, whether it's a work day or a weekday, or a weekend. And then, also, again, I'll keep saying it, but exercise is super important. And we've shown that exercise helps sleep in Parkinson's. We had a big study that showed that. And so it's very, very important to have a consistent exercise program. Of course, that helps the Parkinson's too. Making sure that you don't do things in bed other than sleep or have sex. So no electronics in bed, no telephone. Don't flip through the iPhone while you're sleeping or supposed to be sleeping while you're in bed. Don't watch TV in bed. And in fact, we tell our patients to just completely remove the television from the bedroom so that they're not tempted to do that. And there are kind of two reasons for that. One is that the television and the telephone, they have light that is alerting and can make it harder for you to go to sleep because of the light, which helps wake you up. But then also, you really just don't want to associate your bed with anything other than sleep because then your brain expects to do other things there. You really want to train your brain that when your head hits that pillow, when you get into that bed, that's what you do there. You sleep and that's it. And so that there's a alternate way of looking at that. If you're laying in bed and having insomnia and not being able to fall back to sleep, it's actually really important to get up out of bed and go to a different room. And, if you have terrible balance problems and you're unsafe getting out of bed, then of course that might not be an option. But if you can safely get up and walk with some low level lighting, it's good to have little night lights along the hallway to help you navigate the house safely. But not staying in your bed when you're not able to sleep, especially by the time you become anxious or frustrated by not being able to sleep. If you're worried about, oh, I've only got an hour left to sleep, or I've only been an hour asleep for an hour and I have to get up for work and I can't sleep, then, you start associating your bed with a stressful place. So good to get up, go to a different room, do something that you find relaxing. Definitely don't do any daytime chores. Don't clean the house when you're not sleeping. Don't try to be productive, because that will make you more awake and less able to go back to sleep, which is what your goal is during the night. Never pay bills at night. Don't do work. So designate your sleep time hours, and those are just for sleep. So do something relaxing. If you're going to read, don't read a book that's hard to put down. Read something boring, like maybe some deep molecular science. um, or if you're going to watch TV, don't turn on an action movie or something that you don't want to turn off. So,
Right.
Things like that. And then as soon as you feel drowsy, go back to bed.
Yeah.
And if you don't sleep at all, like if you only slept for 2 hours that night, still get up at your normal time, because again, it's really important to keep that schedule. You can take a brief nap. Like I said, 20, 30 minutes should be your maximum nap duration, because otherwise you can disrupt your nighttime sleep. But yeah, try to wait and sleep at your normal time. And don't watch the clock at night, because that's stressful too. Like I said, if you're looking at the clock and noticing, oh my gosh, I've got to get up in an hour and I can't sleep, or again, I've only been asleep for 30 minutes and now I'm awake again, just set your alarm and know that it'll go off when it's time to be up, and just don't look at the clock during the night. So those are some of the main things that I tell people.
Yeah, no, this is wonderful. And then I guess, a few things, if I may add, limiting the excess fluid intake, I guess, during the late evening hours, right? And not drinking caffeine.
Oh, absolutely.
Towards
Yeah.
bedtime.
Very important. Thank
Uh,
you for mentioning that.
and then the last one thing I was gonna say was, oh, there. I have one question. Timing of exercise when it comes to bedtime. Do you think that sometimes if you exercise close to bedtime and you take a warm shower, is that helpful, or would that be too alerting?
There for a really long time, it was said that exercising too late in the evening could disrupt sleep. And I think there's been a little bit of question about that data, but I don't think it's really decided yet. So, I think if the only time of day you can exercise is in the evening, and it's probably more important to get some exercise than to not get any, but just because it's in the evening. You mentioned the hot baths at night. I think one of the reasons that works is because one of the ways that we fall asleep is to have a gradient in our body temperature. So if you get your body temperature warmer by your hot bath, then you have more of a room to decrease, and that can help you fall asleep. So exercise could help with that. But really, I think it's not quite yet known what the true answer is for that. But exercise is so important that like I said, if nighttime is the only time you can get yourself to do it, then that's when you should. But if morning works for you, then go for that.
Definitely. And my last question before we open it out to the audience is sleep and DVS. And Amy and I wrote a paper on this. So what can you briefly tell us about DVS as what it would do to sleep?
So DBS helps with the motor symptoms. So for people who are having trouble with sleep because they can't roll over in bed, it might be life-saving. Most people who get DBS feel like they're sleeping better. When we look at actual sleep studies, the data is a little bit less conclusive. So some people with DBS sleep better on their sleep studies, and some people just don't. But a lot of times people feel like they're sleeping better, so that's just as important. DBS can probably be more helpful and probably not harmful to sleep. And I actually just heard an interesting lecture earlier this week about targeting a different area of the brain with DBS in Parkinson's to help sleep. Someone put an electrode in the reticular nucleus of the thalamus, and the person slept better. But it was just one case so far, so we'll see what happens. But it hopefully will be somewhat helpful and probably not harmful. So.
Yeah, wonderful. I think this is really great information, Dr. Amara, and I'm gonna see if what kind of questions we have. We talked about RLS. Let me see. Is there any evidence that music for sleep such as by Steve Halpern or acupuncture, have a quieting effect on violent dreams during REM sleep. We have some experience with both, along with exercise and melatonin.
I'm not aware of evidence about music and acupuncture. It may just be because I haven't read those data. But I think for music that's relaxing, if that is helpful to the person who's trying to fall asleep, then absolutely. It can certainly vary from person to person. You certainly don't want to, or probably don't want a rock band, and I don't know that musician that was mentioned, but I think acupuncture is a fascinating treatment. And again, I don't know a whole lot about it, but I think, if it seems to help someone, then, why not? Whatever works, do it, as long as it's not harmful. I don't, and exercise, we already talked about. I'm definitely a fan of that. Do exercise for sure.
Yeah, me too. So there's a question. I've had insomnia for at least 10 years, had recent knee surgery and was put on tramadol for pain and gabapentin for nerve pain. Last 2 weeks have gotten amazing sleep. I attribute this to gabapentin. Can this be scripted for a long-term sleep aid?
So gabapentin, recently there's some evidence that it shouldn't be combined with narcotics, but gabapentin I think is an excellent medication for lots and lots of things. So we use it a lot in restless leg syndrome, and it really has the added benefit that it can help people sleep. So I think taking gabapentin at a not a super high dose, but a cautious dose, and being aware that it can sometimes at higher doses impair balance. So you do have to be cautious and, take it from person to person and how it's affecting you. But yes, if you do get better sleep with gabapentin and it's not causing any side effects, then I think it's fantastic. It does actually increase that slow wave sleep, delta sleep, which is so important for cognition. So it can be really useful. I think it's a good medicine.
Yeah, absolutely. I did not specifically ask you about obviously the sleep, sleep medicines per se. Like, do you, is there any role like for sedatives, and do you use them, or it's really individual patient, I guess?
Yeah, I rarely prescribe them unless there's another reason. So, if, for example, the clonazepam for REM sleep behavior disorder, but I can count on my hand on maybe on two hands the number of times I've prescribed things like Ambien or Restoril or things like that. It's just usually if I prescribe it, it's because someone's already on it when they come to see me for the first time. So I think really focusing on sleep habits and doing the other things correctly is more important, because those medicines, people do get dependent on them, and then it's harder to sleep later when you try to come off of them. And I mentioned trazodone earlier, which is, can be used if someone has depression and sleep problems. That one is not such a sedative, but I try to avoid the use of sedatives. Sometimes I give them if someone has a lot of anxiety related to sleep, just so they can have it available if they have a terrible night, and use it maybe once a week at most. And that can be helpful just to make you feel more comfortable knowing that you have that if you need it. And just reducing that stress of not having something if you need it can actually help you sleep better. So those are the situations when I use it most often.
So, I think the take home message, from everything that, the excellent information that you gave us says that you really have to try to, really get a good history from your patient and try to really identify like what is it that's, and then sometimes, I really almost call the patient in for a sleep visit, although, because the wait times for sleep doctors is so long, sometimes they're just like, let's just talk about your sleep. And, what time do you normally go to bed? Like, it's just the consistency. And like you talked about, trying to find the cause of the sleep dysfunction more. So a lot of times, you can definitely get them treated. Somebody said, how do you locate a neurologist who specializes in REM behavioral disorders? I guess we all have sleep doctors, right, in our department, and we can refer them. So you just have to ask a neurologist. Or sometimes, if you're lucky and you have Cindy Comella or Amy Amara, who are movement doctors, but also at the same time sleep doctors of William Ondo, then you basically talk to them about it, right?
Yeah.
I have insomnia and restless leg, and have not been given any treatment. Why? I guess you got to talk to your doctor about it. Any
Yeah,
comment?
if you're having restless legs, like I said, checking your labs for low iron or low vitamin levels can be really helpful. And then, like I said, exercise helps with RLS too, but there are medications that can help it. So yeah, absolutely mention it to your doctor. And if they, don't seem to have that as something that they typically treat, then ask to go see a sleep doctor, because we see that all the time.
Yes, absolutely. Trouble sleeping for years, tried it all, took NyQuil and sleep really well. Is there a problem with long-term use of NyQuil?
And NyQuil often has Benadryl in it, which can impair the memory. So Benadryl is an antihistamine, and it actually causes some long-term memory problems if you take it for a while. And that's, if may not impact people who are younger, but especially as people get older, over the ages of 55, 60, it can really lead to some cognitive problems. So I do think not using it long-term is a good idea.
Yeah, absolutely. Um, Dr. Amara, do you refer any of your patients who have insomnia issues to a psychologist who does CBT for insomnia? That's a good
I
one.
do that quite often, actually. We're very fortunate to work with someone who specializes in that at UAB. He used to be a sleep tech, and then he does research in insomnia, and so he does cognitive behavioral therapy for insomnia. But if you don't have a practitioner for that who lives close to you, there is a cool app that is called CBTI Coach. That, of course, is not as good as having an actual therapist, but does have some really great strategies. And there's some breathing exercises on there, some other things that can be really helpful.
CBTI coach. We
Yeah.
will look for it.
Yeah.
Does iron interfere with Parkinson's meds, carbidopa, levodopa?
No, there's not any interaction with those as far as I know. They work just fine together.
Yeah. And can using the wrong pillow along with PD stiffness cause myofascial tender points at the back of the scalp, behind the neck and shoulders?
Um, yeah. I think getting the right pillow is probably important, especially if you feel uncomfortable while you sleep. I don't have a particular one that I recommend. My my husband and I do have kind of fancy pillows. I don't even know what they are. He bought them, but yeah, if you have a really thin pillow and you feel uncomfortable sleeping, you might need a more fluffy one, more with more padding. Or if you really feel uncomfortable with your head being too elevated, it might vary from person to person, but certainly your bed, your mattress, your pillow, and those things can all influence sleep. And there's some at least anecdotal things saying that the weighted blankets might be helpful for people who are having sleep problems and insomnia. Certainly haven't seen any research on that, but that's something also to consider if you're not sleeping well.
Goose down. That's what I recommend. The Ritz-Carlton goose down pillow.
Oh, nice.
That's probably what your husband got. uh, okay, you mentioned that using so much energy tossing and turning prevents someone from resuming sleep. Is there a way to control this, like bed position?
You can get things that like bed rails that you can tuck under the mattress, and that can help give you leverage to roll over better in the bed. You also can get satiny sheets and pajamas, so that you slide a little bit more easily through the bed instead of cotton sheets and pajamas. You have to be careful when you if you sit on the edge of the bed, you don't want to go flying off. But there are actually companies that make sheets, or I've seen these in the past, where there's the satin in the center of the bed, but then it's got a cotton rim around the edge so that you can more safely sit on the edge. But yeah, and then there are little trapeze bars that can be portable and hang over the bed to, again, give you leverage if you need help rolling over. So those can be helpful, or you might just need an adjustment of your medications at bedtime. Like sometimes we use the long-acting carbidopa, levodopa at bedtime to help people have better control of their stiffness and slowness while they're in sleep. So hopefully that answered the question. That's some of the things we typically try to do.
Let me see. One last one. Is there any therapy that works for helping someone with Parkinson's for going to sleep? I've tried several sleep meds, but nothing works. I think you kind of answered that before, but
Yeah, I mean, exercise, making sure you keep a consistent bedtime and wake up time, um, and doing things that, uh, help you relax at night, avoiding stressful activities in the evening, and um, some of the other sleep hygiene things that we talked about. But I agree, a lot of times sleep aid medications just don't work. But the cognitive behavioral therapy has been shown to be very effective. So maybe try that CBI, CBTI coach, or try to get a CBTI practitioner you can go see.
rigidity during sleep and difficulty getting out of bed in the morning. I'm taking carbidopa, levodopa. I notice I dream just about every night now, but not bad dreams. I mean, this is normal.
Yeah, sometimes people mention that they notice their dreams more when they're taking the medication, but as long as it's, not making you scared or act out your dreams, that's good. And, rigidity during the night, I think, can't be helped by taking the carbidopa, levodopa at bedtime. So hopefully that's going to help you a lot more.
Yeah, or an extended release formulation. Um, how do you manage periodic insomnia when my husband has Parkinson's disease, dementia? He wakes up during the night, starts prowling around house, not realizing it's 2 a.m. I've clocks in every room, but that doesn't help. He takes melatonin every night, which does help, but how do I stop him from periodically prowling around the house during sleep hours? He and I both lose sleep as a result. Mm.
Yeah, that's a really hard thing to treat when that happens. You know, making sure that you're avoiding letting him sleep during the daytime, keeping him really active during the day as much as possible, so that it really makes his brain recognize that nighttime is time to sleep. He might just have a circadian rhythm dysfunction that's keeping his brain from knowing when he's supposed to be sleeping. If melatonin's not helping, it may be that something else that makes him sleepy, like a medicine to help with, I don't know if he has hallucinations. Sometimes we use a very low dose of Seroquel or something like that at bedtime. Of course, you would have to talk with your doctor about that. That can have some risks in people who are older. But yeah, it is a very challenging thing to sleep. I mean, to treat when you have those problems at night, but really avoiding daytime sleep and trying to have a consistent schedule and redirect him as much as you can to get back to bed. But I'm sorry, that one's a really hard one to take care of.
Yeah, definitely. I think why why do the acting out dreams only happens occasionally? Would that be an indication for melatonin?
I mean, that's a good question. So if there's not any injury with the acting out dreams and they're not terribly disruptive, nobody's getting hurt or falling out of bed, then I sometimes don't treat for those situations if it's just happening intermittently. Because yeah, if you're taking a nightly medication for something that only happens once every 2 or 3 months, then that's probably a bit much. However, if that once every 2 or 3 months leads to someone getting punched in bed or falling out of bed or breaking a bone, then it might be worth it. So it kind of varies based on severity.
I think that's pretty much every. I think we answered every single question. And Dr. Mara, thank you so much for your time and insight. And
I do see a few in the Q&A bar.
yeah.
I think we were looking at the chat, but
Dr. Mar, there's one specifically from one of our caregivers. She asked about addressing sleep for the sleep partner. Any strategies that you haven't shared already that you think would be specific to a care partner?
Care partner. So this, similar things as what we said for others. Occasionally, seeing if you can get someone to stay overnight. I know that's a hard thing to do probably, but having a break might be a good thing, at least intermittently. And making sure that you are taking care of yourself, trying to get exercise for you. Hopefully you can find something that the two of you can do together. That can be helpful sometimes. Avoiding caffeine late in the day, avoiding naps during the day, and So yeah, I agree. It's very important for the care partner to get good sleep as well, because you need to be there for your partner, and so you need to take care of yourself too.
Absolutely. Interesting question here on the Apple Watch. I know we talked about this last time as well in our last webinar. Are you aware of the sleep app on the Apple Watch and any research that's been done using that technology regarding how accurate it is to track sleep?
I think so. I'm not sure specifically about the Apple Watch. We use things called actigraphy that can tell the difference between being asleep and being awake, and I think they probably do a pretty good job at distinguishing sleep from wake. It's a little bit harder in Parkinson's because people with Parkinson's act out dreams sometimes, and so you might be moving quite a bit in sleep and actually be sleeping, and it might interpret that as being awake. I don't think there's any technology yet that's very good at detecting differences between different sleep stages. So, if your watch is telling you you're not getting enough deep sleep, then I wouldn't become alarmed. If you feel good during the day and feel like you're sleeping well, then probably you are. If you don't feel like you're sleeping well and you feel lousy and sleepy during the day, then probably you need to work on your sleep. But I generally try to tell people not to give too much credence to those watches as far as telling different sleep stages. But just basically go by how you feel during the daytime.
Sure.
People
Mr.
are certainly trying
Desai
to improve those, though. I'm sorry, I didn't mean to interrupt you.
Oh, absolutely. No problem. Mr. Desai says he does meditation every night for 20 to 40 minutes, and that helps him a lot. Thank you for sharing that, Mr. Desai. Any other thoughts on that, Dr. Amara, regarding meditation?
Yeah, I think that's a great strategy. Sleep relaxation in general, it can be meditation or prayer or deep breathing. And I think the CBTI coach that I mentioned has some recommendations for that also. Sleep relaxation techniques or meditation at bedtime can be really helpful to calm the mind, relax the body, and help you get to sleep better. So I have heard our practitioner of CBTI, the cognitive behavioral therapy for insomnia, mention that it's important to practice your techniques when you're not trying to fall asleep, to kind of train yourself how to do them before you try to use them related to sleep, so that it doesn't become a stressful experience as you're trying to learn it and it doesn't work for sleep at first. So that can be one helpful thing. But yeah, thank you for sharing that. That's a good point.
And we've got one last thing here, personal testimony from one of our caregivers. She says she has a spouse and that has been using the Bose sleep earbuds, and this has significantly helped sleep maintenance. Is there any research on using this technology for persons with PD or sleep partners for persons with PD that you're aware of?
Oh, I don't know about that. I'm going to have to look that up. I'm sorry. Thank you for sharing that, but I haven't heard about that. So I'll look that up. Thank you for sharing it.
Okay, great. Dr. Chitnis, any other closing remarks?
No, I think this has been really informative. I think this is, each area of part of Parkinson's can be a talk by itself. So, we just learned so much about sleep disorders from Dr. Amara, who's a real expert and does original research. So thank you, Amy. Firstly, it was great to hang out with you. Secondly, thanks for sharing your wisdom with all our patients in the DFW area. And
yeah, it's been really great to be here, and I appreciate all of you listening in.
Thank you, Dr. Amar. I appreciate your time so much. I know our patients and our caregivers loved it. Tons of questions. Thank you so much for being engaged and for attending tonight. And we will be posting this on our YouTube channel for those of you who have care partners that weren't able to make it, or if you missed any portion of this, you can watch that at your convenience later on. Thank you, Dr. Chitnis, as always, for moderating. We do have our next Ask the Doctor coming up on April 6th, so we will be sending out information on that via email so that you guys can register. Until then, take care, everyone, and have a great night. And thanks again.